Okay. Great. Thank you. I'm going to just this, get rid of the little pictures here. Okay. So, first of all, the title of my talk is What Causes Vascular Side Effects Associated with Anti-Amyloid Antibodies and How Can We Mitigate Them? These are my disclosures. So I do quite a bit of consulting and serve as an advisor and have funding from NIH, NASA, and Cure Alzheimer's Fund. So I'm going to just try to move this stuff that's blocking this top of my screen here. Put down at the bottom. Okay. So today I'll give a very brief overview of Alzheimer's disease and also vascular amyloid, which is known as congophilic amyloid angiopathy. Then I'll talk a little bit about an anti-amyloid antibody-induced ARIA, what it is, where it occurs in the brain, that sort of thing. And then I'll talk a little bit about whether or not non-clinical, what we used to call preclinical, and now we call it non-clinical studies, predict anti-amyloid antibody-induced ARIA. And then next I'll talk about the potential role of complement in ARIA. This is a huge focus in my lab right now. And then I'll talk about 3 potential strategies to mitigate ARIA and boost efficacy. And lastly, I'll go through a quick summary and talk about some of the lingering questions for the future. There's still a lot we don't know, and hopefully it'll motivate others to start working in this field to try and answer some of these questions. Oh, sorry. Okay, so this is Alzheimer's disease pathogenesis and its effects. This is a diagram made together between myself and Maria Josie Papaverdi, who's a Ph.D. student in my lab, using BioRender. And this is showing an Alzheimer brain here where you can see, typically both sides of the brain would be like this, but it's control brain on the left, and on the right is an Alzheimer brain where you can see shrinkage of the brain, otherwise known as atrophy. Before we get to that point, though, there is an accumulation of A beta oligomers, which are small soluble aggregates of beta amyloid protein, A beta protofibrils, and finally amyloid plaques. There's also amyloid accumulation in the vasculature. As I mentioned, that's called congophilic amyloid angiopathy. There are also changes in phosphorylation of tau, and this causes aggregation of tau. And then you start to see these intracellular neurofibrillary tangles being formed. And those are not good for neurons and can affect neuronal function. There's also synapse loss, which is also not good for neuronal function. And then there's also inflammation and blood-brain barrier disruption. And this inflammation is visualized by activation of microglia and astrocytes and other immune cells in and around the brain. And then lastly, there's neurodegeneration and frank neuronal loss. And it's been said that roughly 40% of neurons are lost in the hippocampus of someone with moderate to severe Alzheimer's disease. So this leads to this is actually associated with insulin resistance and reduced glucose metabolism, the latter of which is seen by FDG PET imaging. And taken together, all of these can lead to anxiety, depression, and memory loss in Alzheimer's disease. And I just want to point out that these things occur over many years. It's not an overnight disease. It's a very long-term chronic disease. So I mentioned that there's amyloid that can accrue in blood vessels. This can be either in conjunction with Alzheimer's disease, but there are also conditions where amyloid accumulates in the vasculature, but the people don't have Alzheimer's disease. The patients don't have Alzheimer's, and that's CAA and CAA-RI, which is CAA, cerebral amyloid angiopathy, and RI is related inflammation. So before we get started, I just wanted to talk a little bit about the normal physiological state of blood vessels and also the pathologic state when amyloid is present. So arteries are large vessels that have the lumen here, shown there's these little red dots or soluble beta amyloid. So here's the lumen. Then the light pink is the endothelial cell layer, and this is surrounded by the smooth muscle cell layer. And I want to note here that APP is expressed in the smooth muscle cell layer. And then there's also this basement membrane, which here they're showing as collagen. So there's a lot of collagen in this area. Then there's an area called perivascular space. And then there's the surrounding by the end feet of astrocytes along the blood vessel wall. And then in veins, it's similar, except for that there's no smooth muscle cell layer. Now, when CAA occurs in arteries or arterioles that contain smooth muscle cells, you see this buildup of amyloid shown in the dark red here, buildup of amyloid in the collagen basement membrane layer. And this can even split that layer, as shown here. And this also causes disruption and degeneration of the smooth muscle cells and endothelial cells. So what I want you to notice here is that there's enlargement of perivascular space and there's disruption, so that there's disruption that basically goes right from the bloodstream to this layer here that contains the amyloid. And there's also this enlargement of the perivascular space. And in veins, when amyloid accumulates, it typically accumulates as these clumps in the perivascular space on the outside of the collagen layer. The collagen layer gets enlarged, and you again see this disruption of the endothelial layer. And this will become important later on in my talk. I'll show you why. So as many of you I'm sure have heard, there has been a lot of research over the past 23 to 25 years looking at antibodies and active immunization and then passive immunization, targeting beta amyloid to help clear beta amyloid out of the brain and to either prevent or slow the progression of Alzheimer's disease. And so here I just wanted to mention some of the antibodies that have gone into clinical trials. So one is solanezumab. This binds a mid-region in beta amyloid and binds to soluble A beta. Then there's gantenerumab, which binds actually two epitopes within the N-terminus, but not the N-terminus ASP1 in particular. And this blocks fibril elongation. There's also aducanumab, which blocks more of the fibril formation and is recognized. It binds to fibrils. It also binds to prefibrils. And then there's lecanemab, which binds to protofibrils, and donanemab, which binds to plaques. And this is, donanemab binds a protein near and dear to my heart called pyroglutamate-free beta amyloid, which we believe is a seed for plaque deposition in the brain. And so pyroglutamate-3 beta amyloid is this N-terminally truncated and modified form. And so it has also been in clinical trials. So as I'm sure you've heard, in 2021, Biogen was granted accelerated approval by the FDA for Aduhelm, which is the aducanumab antibody. This was quite controversial because there was one positive trial and one that was not so positive. However, the data, when it was looked post hoc at the higher level dose, they did see a trend for, it did look like it was having some benefit. And so the FDA gave accelerated approval for this antibody in 2021. In January of last year, 1 year ago, the FDA gave accelerated approval to Eisai Biogen for Leqembi, which is an antibody known as lecanemab. And this antibody was initially discovered and characterized by Lars Lannfeldt's group at BioArctic in Sweden. And this antibody recognizes protofibrillar forms of beta amyloid. And it requires dosing every other week, whereas Aduhelm is every month. This one is every 2 weeks. But it seems to have very strong benefit and seems to be a little bit safer. And I'll get more into that later. It received full FDA approval in July of 2023 and is actually rolling out in the clinics now. And then lastly, Eli Lilly has shown recently very nice phase 3 clinical trial data showing strong effects of plaque lowering and cognitive slowing of cognitive decline. And this antibody called donanemab, which is against pyroglutamate 3 beta amyloid, is pending FDA approval. I should also mention there is another pyroglutamate 3 beta amyloid antibody that is from Bavarian Therapeutics in Germany. And that antibody has been licensed to Simcere. I think it's Simcere Therapeutics in China and is in phase 1 clinical trials right now. And that's an antibody that I'll show you something about later, something that we've worked on for years. So one of the side effects that's seen with, or the main side effect that's seen with these anti-amyloid antibodies, at least with the ones that bind to plaque amyloid, is that individuals start having either vascular swelling or edema, vasogenic edema in the brain, or microhemorrhages or superficial cirrhosis. And so this is called amyloid-related imaging abnormalities because it was seen on MRI after treatment, and it's known as ARIA. And one thing I want to point out here is that ARIA is not specific to anti-amyloid immunotherapy. There are people that have ARIA separate from anti-amyloid immunotherapy treatment. And there has been ARIA also seen with other antibodies. For example, TREM2 antibodies have been tested in the clinic recently and also induced ARIA. So it's not completely specific, but I think it might have something to do with the vasculature. Anyways, it's been shown there are 2 different imaging methodologies, FLAIR and T2 star imaging, or susceptibility weighted imaging for ARIA E and H respectively. And as I mentioned, most of these plaque binding antibodies are all, to my knowledge, all of the plaque binding antibodies, except for maybe crenuzumab, which is on a different Ig isotype, Ig backbone, have induced ARIA. Solanezumab, the one that binds a mid-region section of beta epitope in A beta and only binds to soluble A beta, does not induce ARIA, but it's also not very effective at clearing amyloid or improving cognition. This ARIA has been seen, depending on the antibody, in roughly 12 to 40% of patients, especially in ApoE4 carriers. And ApoE4 is the strongest risk gene beyond aging for Alzheimer's disease. And it seems to be a gene dosage effect. People with 2 copies of E4 have even higher rates of ARIA. Most ARIA E is asymptomatic and transient. However, some severe ARIA has been seen and can be quite serious. So I really like this figure because it gives sort of an idea of what's going on, what the differences are between ARIA E, edema, and effusion. So edema is when you get leakage of this intravascular fluid into the parenchymal interstitial fluid compartment, whereas effusion is when the leakage of this fluid is going into the leptomeningeal and subarachnoid space. And both of these have been seen with anti-amyloid immunotherapy. ARIA H is seen as the leakage of blood degradation products, including iron, which is released from red blood cells, into the adjacent brain parenchyma. And then superficial siderosis is leakage of the same things, but into the subarachnoid space. And as I mentioned, the risk factors for ARIA are exposure to anti-A beta antibody treatment, the presence of pretreatment microhemorrhages. So now people are being screened to make sure that they don't have more than 4 microhemorrhages. Otherwise, it's recommended that they not start this therapy. And then also ApoE4 carrier status. So many clinics now are performing ApoE genotyping so that they can better assess the risks of treatment with the approved antibodies. So this is just a table that Steve Salloway from Brown loaned to me, and this is showing ARIA E rates with the antibodies that have gone to clinical trial, and combined means E4 carriers, heterozygotes, and homozygotes all combined. And as you can see, there are different rates. Bapineuzumab was the earliest antibody to go into clinical trials. However, it induced ARIA, and at the time, they kept lowering the dose. So it's a very low dose. It did not end up showing clinical benefit, probably because not enough antibody was getting into the brain. And that is no longer in the clinic. Clinical trials are being developed. Aducanumab, excuse me. Aducanumab has a combined ARIA rate of 35.2%, which is the highest of all of them. In E4 carriers, roughly E4 non-carriers, about 20% of people showed ARIA-E. Heterozygotes for E, one copy of ApoE4, 41%. And then people with two copies of E4, 66% showed some sign of ARIA. Now keep in mind, some of this is transient. Most of it is transient ARIA, and the patients don't even know that they have it. It's completely asymptomatic. It's just seen on imaging. However, in some individuals, it can be very serious. This is about 1% of individual patients in clinical trials thus far. Now, ARIA-H rates are a little bit, they tend to vary a little bit more and are not seen as much with some of the antibodies at least. And this is showing gantenerumab, this is aducanumab, this one is lecanemab, and this is donanemab. And here you can see, for example, with donanemab, that at the end of the trial, yes, there were a number of, there was a large increase in the number of microhemorrhages in the combined E4 carriers and non-carriers. However, I want to point out here that it seems that from all of the clinical data obtained so far, that ARIA-H follows ARIA-E. Most of the patients that develop ARIA-H had ARIA-E early on in their treatment. And then this is just an example of what can go very wrong. And so this is a 65-year-old patient with early Alzheimer's disease. She was an ApoE44 individual, and she had no microcerebral bleeds, no microhemorrhages at the time of immunization or the time of joining this trial. She was in the Clarity phase 3 trial by Eisai and Biogen, and she was on the placebo dose for the first part of the trial. And then during the open label extension, she was allowed to go on lecanemab. And so she went on, she had 3 doses. So that's every 2 weeks, 1 dose. So she had 3 doses. And then 4 days after her 3rd dose, she developed stroke-like symptoms and had aphasia and seizures. She was taken to the ER, and they thought that she was having a stroke. And so they treated her with TPA, which is a blood thinner, and she had massive hemorrhaging. And so her family consented to autopsy, and you can see that there's microhemorrhages, there's a fusion in the brain, so ARIA-E and H. You can see the hemorrhages here. And along the blood vessels that contain amyloid, you can also see this recruitment of all these different immune cells coming into the vasculature and the presence of these giant multinucleated cells, which are also thought to be immune cells. And then here, what was interesting is that the amyloid tended to be very broken up. And so whether or not this is an attempt of the antibodies to clear the vascular amyloid or is a side effect of all of the immune activation, we really don't know. But that's something we're hoping to understand better. So one question that comes up is anti-amyloid monoclonal antibody-induced ARIA iatrogenic CAARI? And as I mentioned, CAARI is this vascular amyloid-related inflammation. And this is a neurologic condition. It's rare, but it's a spontaneous condition. And it's been noted that people with this condition have high levels of anti-A beta autoantibodies. This also involves the activation of microglia, and this is seen with TSPO PET imaging, and it's resolved with corticosteroid treatment over weeks to months. And this mimics many of the same features of anti-amyloid immunotherapy-related ARIA. So on the top, this is anti-amyloid immunotherapy ARIA, and on the bottom, this is more the CAA-RI ARIA, both ARIA-E and ARIA-H. So was this predicted by preclinical studies in amyloid mouse models? Well, it's known that as early as 2002, Pfeiffer and Euchler showed that if you immunize, they did immunize old APP23 mice. So this particular mouse model develops quite a bit of vascular amyloid and even develops spontaneous microhemorrhages associated with that vascular amyloid with age. So they immunized the mice with an antibody that recognized A beta 3 to 6 and terminus of A beta. It binds to plaques very well. And they treated the mice weekly for 5 months. And they did see, so this is a control mouse and this is a treated mouse. And you can see that they did see plaque lowering, but they also saw the presence of microhemorrhages. And this is in the control mouse and this is in the treated mouse. You can see a lot more microhemorrhages in the treated mouse. And then this is just showing the microhemorrhage frequency and severity and the hemorrhage score in these mice. So very early on, even as early as 2002, it was thought that these antibody therapy could lead to hemorrhage and microhemorrhage in mice. So this is the next paper that came out on this topic, and this was from Donna Wilcock and Dave Morgan's group, and showing that now treating a different mouse model, 2576, that develops some, they don't develop a ton of CAA, but they do develop some, and they treated these mice with weekly for either 1, 2, 3, or 5 months with an antibody that recognizes the C terminus, A beta 28 to 40. And this antibody did clear plaques and led to cognitive benefit, but it also increased the amount of vascular amyloid and microhemorrhages, shown here in Prussian blue, which stains iron. And this is a control mouse. You can see there's vascular amyloid shown here in Congo red, and it's associated with some immune cells. But here in the mice that were immunized, these vessels were associated with much more gliosis. And following that, Margaret Racky and Ron D'Amatos showed that they compared the bapineuzumab antibody precursor called 3D6 with the solanezumab precursor 266. And they found that 3D6 resulted in microhemorrhages and even some macrohemorrhages. And this was in the PDAPP mouse model at quite old ages. And then finally, Sally Schroeder and Dora Games from Milan Pharmaceuticals, and these are the folks that were working on bapineuzumab clinically. They did a study in PDAPP mice from 12 to 18 months of age. So at 12 months of age, we've done a lot of work with this model. At 12 months of age, they have some vascular amyloid, but not a lot. So what they showed was that at the end of the study, at 18 months, the blood vessels had lots of amyloid surrounding the blood vessels. In the mice that were treated with the bapineuzumab precursor, you can see that it looks like amyloid is being stripped away from the blood vessels. And they also showed that at different doses, there was more clearance of both plaque and vascular amyloid. And with increasing doses, also more hemorrhaging, more microhemorrhages. And here I want to just point out that most of these microhemorrhages take place along the peel surface, the leptomeningeal blood vessels, and the penetrating arterioles, these large vessels, all of which have the smooth muscle cells. So next, Donna Wilcock went back to the mice that she published in 2004, and she, these are mice that were immunized with the A beta 40 specific antibody, and she looked at matrix metalloproteinases in these mice and saw that very early on there was an elevation in MMP2, and that later on there was a a reduction in TIMP2, which is a regulator, an inhibitor of MMP2. And then she saw that starting around 2 and 3 months following immunization dosing, she started to see the increase in MMP9 and again a reduction in TIMP1, at least compared to 1 month after 1 month of immunization. So it looks like, you know, both the activation of the MMP2 and the MMP9 systems are at play here. So we're wondering which immune cells play a role in ARIA. And as I mentioned, it looks like a lot of the amyloid is along these peel arteries and the penetrating arterioles. And then there's the capillaries. In our mouse models, we don't see a lot of beta amyloid in the capillaries. We see it mostly in these larger blood vessels. But along here, there's also, wherever there's white here, this is perivascular space. And there are these perivascular macrophages, there are meningeal macrophages. And then there are also vessel-associated microglia. So this is around a capillary. And you can see that there's microglia on the outside here, and then right up along the edge of the blood vessel are pericytes. And then in the perivascular space, in the larger vessels, you can see that there are these perivascular macrophages. There's also microglia on the outside here, but there is this big influx of perivascular macrophages. And so Rhonda Matos at Eli Lilly recently published this paper very nicely showing that they're using an APP knock-in mouse crossed to a human tau mouse. The tau part is not relevant here, but the fact that these mice, when they get really old, 23 to 26, do develop vascular amyloid, which is shown here with this dye, X34. And when they develop vascular amyloid, they also develop some CD169 perivascular macrophage recruitment to that area. But in animals that are immunized, here they use biotinylated 3D6, and they can see very direct colocalization with A beta along the blood vessel wall, and a very strong colocalization with perivascular macrophages, and this is shown here below. And this is in the leptomeninges, and then this is in the penetrating vessels. Up above, these are the Ig isotype control-treated animals. And they also found that in addition to the recruitment of these perivascular macrophages, they also found enhanced MMP9 and reduced TIMP1 staining in these animals. So we're curious what initiates ARIA. So for a long time, people have thought that ARIA is due to the dissolving of plaques by antibodies in the parenchyma, and then the shuttling of that soluble A beta now by ApoE to the blood vessel wall, and that then induces this inflammatory cell reaction. Basically, the blood vessel wall gets overwhelmed, and then you start to see inflammation. And this very likely could contribute to it, but based on some studies we've done recently, we think that there might be an alternative hypothesis. And the way we got there was that we were doing treatments with 3D6L, which is the same as 3D6, except for it's a recombinant antibody that our friends in Germany made for us. And this is the bapineuzumab mirroring precursor. And so we were, in this particular study, these mice, so these were very old APP PS1 mice on a humanized ApoE4 background. And I should mention here that we've started doing all of our studies now on amyloid mice on a humanized ApoE4 background. You get a lot more microhemorrhages. And so they make a better model. And so we did MRI imaging. We detected at the end of 13 weeks, we did detect microhemorrhages and some in these animals. And when they were euthanized, we could even see some macrohemorrhages on the surface of the brain. And then when these brains were then fixed and sectioned, you could see quite a bit of microhemorrhage in the brain. And most of it is along the peel surface and the penetrating vessels, so in the leptomeninges. And this is showing the increase in microhemorrhages with this bapineuzumab antibody. This is a pyroglutamate antibody that I mentioned before that's now in clinical trials. This is the murine version 072AK. And this is a pyroglu antibody that that was mutated in the FC region where complement C1q binds, because we hypothesized that maybe blocking complement would help alleviate ARIA. The fact is that these mouse models that we've been using just don't make a lot of pyroglutamate 3 beta amyloid to begin with, and they don't really deposit pyroglue. Very, very, very little pyroglue ends up in the blood vessels. And so we're currently working on new strategies to improve that, to have them make more beta amyloid that starts at pyroglue 3. But we went on then to do acute versus chronic treatment of mice, because we thought, well, in the human clinical trials, ARIA often occurs very early after the second or third treatment. And so we were curious to see where the antibodies are actually binding initially. And so in this study, this mouse was in particular given 3 weekly doses of 3d6. We also did 1 and 2 week doses. In all 3 cases, we saw that the antibody, this is beta amyloid showing the vascular amyloid, and note that these are 2 plaques. And then we noted when we did staining for IgG2A, the isotype of the 3d6 antibody, we noticed that most of the IgG2A was bound wherever there was CAA, but it did not label the plaques. However, in mice that were treated for 13 weeks, the antibody labeled vascular amyloid, but it also labeled a lot of plaque amyloid. And so we think that the antibodies are actually going in and binding to CAA first, and then eventually, after some vascular inflammation and maybe some leakage of the blood-brain barrier, more of the antibodies are getting into the parenchyma, and that's why the clearance of plaques maybe taking a little bit longer. So we then thought about, well, what's going on at the blood vessels in the brain? And in the models that we use, they have a lot of vascular amyloid in the cerebellum and in the meninges over cortex. And so these animals were treated for 15 weeks with 3d6L or an IgG2A isotype. And again, these were the APP-PS1 mice on the E4 background. And what you can see here is the amyloid is shown in blue, both of these images, and you can see that there's vascular amyloid in these mice. And then we looked at C1q, and C1q was also very strongly co-localized with vascular amyloid in the mice that were treated with 3d6, but not with the isotype control antibody. And along with C1q, there were more macrophage and microglia type cells coming over to the blood vessels and expressing CD68, which is a phagocytolytic marker for microglia and macrophages. And so it looks like complement may be getting activated in areas of CAA when mice are treated with this plaque binding antibody. And we don't see upregulation of complement C1q or not a lot of additional co-localization. I mean, there's some inflammation already going on with the CAA, but it just seems to be enhanced or accentuated by the presence of the anti-amyloid antibodies. And then here, Praveen Bettini, who has done the majority of this work in my lab, he's an amazing postdoc. He also looked at C1q and IgG2 antibody labeling to see if we could actually see the antibodies, the amyloid, and the C1q together in the same localization. And again, he was able to demonstrate this both in the cerebellum and in the cortical meninges. And we did not see it overlapping in the IgG isotype controlled treated animals. Praveen has since gone on, this is a different study with different treatment regime, 13 weeks of treatment. But you can see that there is also here the presence of downstream complement molecules, C3b, IC3b, and C3c, in the vasculature of mice treated with 3D6, but not so much with IgG2A. And then again, this is the antibody labeling the blood vessel. And he even has seen an increase in C5b39 staining, which is the very terminal end of the classical complement cascade. And this is known as the membrane attack complex because it actually causes cell lysis and damages and destroys kill cells. So this is some very recent data, like as of today, that I received from Praveen. So this is a study, this is again the APP-PS1 mouse line on the E4 background. These were older mice, 20 months of age. He treated them with 3D6L for 7 weeks, and then he did bulk RNA sequencing, and this is showing the genes that are upregulated in the anti-amyloid treated mice compared to the isotype controls. And so I know these letters are really low, really small font. And so I just want to point out there's a major difference here in the transcriptomics between 3D6L and IgG2A treated mice. And it also looks like there are some sex differences, which I also think is very interesting, at least with 3D6L. And so he has gone on to do all kinds of pathway analysis and has seen that the majority of the changes, upregulation with 3D6, are in complement, C1q, A, B, C, C4b, and C3. In MAC1, which is also part of CR3, the complement receptor 3, and is very important for phagocytosis. Astrocyte, GFAP is upregulated, also some macrophage markers. IgG receptor activity markers are upregulated. Lysosome, Lysi2, and lectins are also including galactin-3. And much of this is immune system processes that are changed, cellular processes. And I mean, the large part of this, the focus here is really that there's a huge change in the immune system with anti-amyloid immunotherapy. And we are now looking at leptomeningeal changes and endothelial changes, and Praveen is in particular focused on pericyte changes. But it'll be a while before we have that data. So this is our hypothetical mechanism for anti-amyloid beta amyloid-related ARIA. So first, we think that vascular amyloid exists along the blood vessel walls, and that the antibodies are coming in through the subarachnoid space and subpial space and may get into the perivascular space. And then these antibodies bind to vascular amyloid. They then get fixed by complement C1q, which is the very first step of the classical complement cascade. And then along comes CR1 and C1s, and these, you need 2 copies of these, and this forms the C1 complex. This then cleaves C4 and C2, and their fragments form C3 convertase. C3 convertase gets cleaved to C3a, which leads to recruitment of immune cells and an inflammatory response, upregulation of pro-inflammatory cytokines at the site of injury or infection. The other thing C3 convertase does is cleave C3 to C3b and IC3b, and those are important for opsonization of immune complexes and phagocytosis of those complexes. And then C3 convertase is then combined with C3b to form C5 convertase, and C5a is generated. And again, like C3a, it binds, C5a binds C5AR. There are 2 versions, 1 and 2. 1 is pro-inflammatory, 2 is anti-inflammatory. But it binds and causes, again, recruitment of immune cells and inflammation. And then the other byproduct is C5b, and this combines with C6, C7, C8, and then with multiple copies of C9 within a cell membrane. And when they all come together, they cause cell lysis. And this is called the membrane attack complex. And I just want to give a shout out to Maria Josie Papaverdi for helping to make this this diagram. So we think that C1q plays a big role, but we also saw this paper that came out a few years ago saying that ApoE and C1q form complexes, and that when ApoE binds C1q, it inhibits the activation of C1q. And what I think is interesting is that in people with E4 alleles, E4 actually causes less binding to C1q. That means it's not able to put the brakes on C1q as well as somebody with an E3 allele. And therefore, this might actually play a role. This is something we're interested in investigating at some point, but I think it's very interesting because if ApoE is sort of chaperoning beta amyloid to the vasculature, and part of its role is to suppress C1q, and in E4 carriers, it's ApoE is unable to contain activation of C1q, you might get a lot more inflammation. And if it goes all the way to the membrane attack complex, you could get degeneration of cells along the vasculature, and that would lead to leakage and eventually microhemorrhages. So what are the implications for anti-amyloid immunotherapy? Well, vascular amyloid appears to be necessary for ARIA, at least in mice, and plaque and vascular amyloid binding antibodies result in increased ARIA. Right now, we're doing a study to try to compare all of the different clinical antibodies for their binding specifically to vascular amyloid. And this might help support this hypothesis that there has to be vascular amyloid present for ARIA. Anti-amyloid antibodies may bind vascular amyloid first and fix complement, thereby initiating a local inflammatory response that recruits immune cells and activates MMPs, causing vascular dysfunction and edema. We have a lot of evidence for this now. I don't have time to go through it all, but we definitely see upregulation of MMPs, especially MMP9. And ApoE4 carriers, even in mice, have more ARIA, but we don't know if that's because they have more vascular amyloid. I mean, people with ApoE4 have more amyloid in general. They have more vascular amyloid, but they also tend to have a different immune response. And so we have to really sort of try to dissect out the mechanism here. And lastly, the implications are that treating early before CAA accrues may help avoid ARIA. And so next I'm going to go through 3 strategies that we've proposed to mitigate ARIA. And I'll tell you, we're waiting. We have mostly positive feedback from NIH, but we're waiting for the funding of these studies. But the first one is to co-treat with an anti-C1s antibody. And so Sanofi has developed an antibody, sutimlimab, which was approved in 2022 for cold agglutinin disease. And this is a disease in which autoantibodies attack red blood cells, leaving patients with very severe anemia. And this antibody blocks the activation of the complement cascade, but it leaves C1q intact. And C1q has some functions that are very helpful, like axon guidance and some others that are necessary and good. You don't want to completely block C1q, but by blocking C1s, it would really block the activation of the classical complement cascade. But it would leave the alternative and lectin pathways intact and thereby protect individuals from infection going forward. And in particular, Sanofi now has a 2nd generation antibody that's in clinical trials for peripheral nervous system disease called chronic inflammatory demyelinating polyneuropathy. And so we are developing a murine version of this antibody and hoping to test it with anti-amyloid antibodies such as 3D6. But what if it was possible to mitigate ARIA, reduce inflammation, and improve both efficacy and vascular function? So we've got 2 possible ways to try to do this. So the first one is a collaboration with Dave Holtzman's lab at WashU. And so Dave has developed this antibody, HAE4. It's an anti-ApoE antibody, and it binds poorly lipidated ApoE, which is exactly the type of ApoE that's found in amyloid deposits, including in CAA. And so he crossed 5XFAD mice. These have multiple APP and presenilin mutations. He crossed these mice with a humanized ApoE4 mouse model and saw that as these mice aged, and these are on the black 6 background, the 5XFAD mice on the mixed background have much more aggressive pathology, and it starts earlier. These start a little bit later, and when you put any mouse model on an E4 background, they start a little bit later again. We don't know why, but it does happen. And so what he noticed is that this mouse model, as it ages, by about 8 months of age, approximately 70% of the amyloid is in the blood vessels, so it's CAA. So proportionally, there's a lot more vascular amyloid than in mice that don't have the E4 background. So he immunized these mice with the anti-ApoE antibody and with a chimeric aducanumab antibody, chimeric to make it murine-ized. And what he found was that both antibodies reduced A beta, although the ApoE antibody reduced it even further. Total A beta, parenchymal A beta, and even vascular A beta was reduced. However, when his group looked at microhemorrhages, they found that, yes, there's a lot of vascular amyloid here stained by thioflavin S, and there's Prussian blue in those blood vessels in the mice that were treated with the chimeric aducanumab antibody, but not with the ApoE antibody. So this is an antibody that does not increase hemorrhages and therefore does not seem to be associated with ARIA. And then they looked at, this was sort of a prescribed RNA-seq. This is really qPCR, but looking at their control mice, the the ApoE antibody mice and the chimeric aducanumab mice. And you can see that there's much more of a downregulation of these inflammatory genes, microglia, astrocyte, and pro-inflammatory cytokine genes, including C1q, I should mention, and C3, and clusterin, which is also an inhibitor of the membrane attack complex. And so it looks like this might have an anti-inflammatory effect, and it seems to, this antibody also functionally improved the vasculature in mice. Through some very fancy methodologies, they were able to establish that. Now, the third method that we propose to try is using glucagon-like peptide 1 receptor agonists, GLP-1 RAs. And I'm sure you've all heard the commercials for Ozempic. Ozempic is semaglutide. It's made by Novo Nordisk, but there are a number of other GLP-1 RAs, and including Mounjaro, which is now out from Eli Lilly and has been FDA approved. And these increase insulin secretion, they increase insulin, this is the pancreas, and they increase insulin sensitivity in the liver. They reduce gastric emptying, reduce caloric intake and fat absorption, and they increase satiety, or that feeling of being full and not having hunger. They also increase insulin sensitivity and have been shown to provide neuroprotection and improve cognition. So this particular group showed that GLP-1R is upregulated in Alzheimer's brain, and that it is also seen upregulated in 5XFAD mice, and that it's expressed mostly on microglia. So this is GLP-1R. And it's expressed mostly on astrocytes and microglia with very little on neurons. And they looked at a GLP-1R agonist called exceedin-4, and found that it reduced plaques in the 5XFAD mouse model, and it did it in a dose-dependent fashion shown here. This is a little bit controversial. Other groups that have used other GLP-1R agonists have not seen plaque reduction. This group did see it. They also saw improvement in behavior in the swimming maze, and they saw a reduction of inflammation, TNF, C1q, IL-1RA, and IL-6. And in particular, they saw a reduction in conversion of astrocytes to A1 type, this toxic or pro-inflammatory type astrocyte. And this is shown with downregulation of GFAP, and also C3 levels. C3, complement C3 is now being used frequently as a marker of A1 astrocytes. The folks at Novo Nordisk have done a number of studies now looking at stroke models and saw that there's a reduction in inflammation shown here with IBA1, the middle cerebral artery occlusion model. And then they also looked in an LPS model in mice, and this is the vehicle control. This is LPS showing a very strong upregulation of immune regulated genes, and that this is normalized back to zero when semaglutide is included with the treatment. And most of these genes that were changed respond or are part of the immune system, including defense response to other organisms, which might include complement. And interestingly, the cells that were involved in this that showed the biggest changes were endothelial cells, microglia, and pericytes, all of which are associated with the vasculature. So these drugs have been in clinical trials for a while now, and there are a number of different ones that have been in clinical trials shown in different colors here. It's been shown that there's less decline in cerebral glucose metabolism and less decline in cognitive function in AD patients. In type 2 diabetes and obesity, it's been shown now that there's a 53% lower risk of all-cause dementia in patients treated with liraglutide or semaglutide. And there's also a reduction in systemic inflammation. And so, this is looking much more promising, again, reduced cognitive decline. In preclinical data or non-clinical data in both Alzheimer's and Parkinson's disease animal models, there's reduced systemic inflammation and inflammation within the brain, and improved vascular health, improved memory function, and improved blood-brain barrier integrity. And as I mentioned, in people with diabetes on these drugs, there's overall a lower risk of all-cause dementia and Alzheimer's dementia. So in summary, ARIA is a risk factor for anti-amyloid antibody treatment that appears to be higher in AD patients with vascular amyloid and an ApoE4 genotype. Anti-amyloid mediated ARIA was predicted by preclinical studies in mice, and cognitive efficacy was seen in mice with plaque clearance and ARIA-H. So even though there's ARIA, there can still be improvement in cognition. And one of the things that I think some of the clinical trials are now looking back at is what was there at the time of ARIA or shortly thereafter, was there actually any change in the cognitive status in the testing? I don't mean during a full-blown episode of ARIA, but shortly thereafter. And then there are a number of potential mitigation strategies, including suppressing the inflammatory response and restoring vascular function, both of which may improve efficacy. And we need much better biomarkers. So right now, CAA and ARIA are determined by MRI imaging, and MRI is not perfect by any means for CAA, but you can see microhemorrhages and superficial cirrhosis. But I think there's also potential for measuring plasma A-beta-40, looking at MMP9 and MMP3 in the blood, perhaps measuring C1q, C3, and C4d in the blood, or the CSF, and then looking at soluble C5b through 9. And the reason I say soluble C5b through 9, there was a paper that came out last year showing these magrosomes. These are macrophage packets that appear in the blood, and that by isolating magrosomes, this group was able to show that soluble C5b through 9 was associated with more CAA. And then it might also be interesting to look at ApoE and C1q complexes in the blood and possibly in the CSF, and to look at iron, since once the vessels start leaking, and especially when they start having microhemorrhages, there's a release of iron from the red blood cells. So the lingering questions are, is CAA absolutely required for ARIA, especially ARIA-E? We really have not seen any proof for that yet. We believe it's true wholeheartedly, but we really need to look at a mouse model that has lots of plaques with no CAA and one with lots of CAA and do a side-by-side comparison with 3D6. That's something we hope to do at some point. The other question is ARIA due to A beta coming or going? Is it the A beta antibody coming into the vasculature and inducing ARIA at that point? Or is it really that the antibody is going into the parenchyma, solubilizing A beta, pulling it to the vasculature, and the vasculature is getting overwhelmed, and that's why we're getting the inflammation? So we're definitely working on that right now. Does the route of administration matter? We don't know yet, but the recent work on trontinemab, I believe that's how you say it, from Roche shows that they're using this transferrin receptor shuttle, which would bring gantenerumab right into the parenchyma to the capillaries. And so far, it looks like they're getting robust clearance with very little ARIA. So again, it might be that if we get it in that way, you don't have this, you don't have, you can bypass that vascular amyloid side effect. But those studies, are ongoing, we'll see. And then how and where do the antibodies enter the CNS? Again, choroid plexus, the peel surface, we don't know yet, but it's an interesting question. Does ApoE4 bind less well to C1q so that compared to ApoE2 or 3, and thereby allow more complement activation? So this is something that could be done quite readily. Are patients with genetic forms of AD at increased risk for ARIA? So for example, it's known that people in Colombia with the presenil and E280A mutation have huge amounts of vascular amyloid and perivascular amyloid. So we have to really think about patients in those populations and people with Down syndrome who also have a lot of ARIA. Are they going to be at increased risk? Have a lot of vascular amyloid. So are they going to be at increased risk for ARIA? And how can we better define those who are at increased risk beyond just ApoE4 genotyping? We really need much better biomarkers for CAA and ARIA. And there is an urgent unmet need to mitigate ARIA and potentially boost the efficacy. And here are my acknowledgements, and I went way too long, I'm sorry. But as I said, I'm happy to stay on. But in particular, I want to point out Praveen Bettini, who did a lot of the work on A-beta immunotherapy in my lab, and especially is working on the complement story now. Maria Josie is also doing some work now on the complement story and immunotherapy. And she and Martine Brennan have done a lot of work just characterizing these mouse models. And I will end there and stop sharing.